So the first thing is you'll be familiar with the audit cycle. I mean, it's been around for a very long time in healthcare. And if there's a problem with it, first of all, it looks backwards, a bit like our data set I showed you earlier. We're still at 61.5 and it'll be 2030 at the current rate before we get anywhere near where we want to get. But it also has this box, which is always in the diagrams, exactly the same size, even if it's a slightly different color from all the other ones. It says make changes. Well, we all know that making changes is not simple. In fact, if Matt just clicks the slide on, in fact, to make a change successfully, all these things in the red box have to happen. And they don't happen by accident, and they don't happen very easily. So this is where quality improvement methods and approaches can really, really help, because it does give you the tools to try and understand the system, and we're using the 5 Ps to do that. It does make you think about the variation, what things work well and when, and how could that happen every time, what things don't work well and why, and what can we do to put that system back together so that it's better. You do need to involve people that normally perhaps you don't necessarily meet on a regular basis, whether that's management, whether that's your QI team, whether that's teachers at the local secondary schools, or social workers, or youth workers. There are people, they're all stakeholders in the improvement you want to make, and connecting with them and sharing with them your purpose and how that might fit over theirs is a really, really important step to take early on, because these people will help you achieve what indeed everybody wants, which is the best outcome for their children. Not just the best output of the system or the lowest HbA1c, but what's the best outcome for that child as they go forward into adult life. I won't read all the things off the list, you can read them yourself, but keeping people enthusiastic is about feedback loops and is about finding out quickly when things aren't working and celebrating when they are and tweaking them a bit to make them even more resilient under pressure. And actually making improvements stick isn't easy either, because systems tend to try and get back to how they were before you change them. And so you really have to think hard about how maybe the IT system supports the change you want to make, the layout in the clinic supports the change you want to make, the way you report the data supports the change you want to make, because all these things will make it very, very difficult for things to go back how they were after all the effort that you've put in over the months ahead as we work together on this. Next slide, please, Matt. So first thing is about team meetings. We've tested out the idea of a timekeeper. I don't know how that worked, but I do know that everybody was back in the room on time. Now, whether that would have happened without a timekeeper, I don't know, but I suspect it wouldn't, because having a timekeeper is a really useful thing for a team to have. But so are all these qualities of a team meeting. That it's disciplined. You stick to what you were going to discuss when you started, and you don't go off track. If something comes up that somebody wants to discuss, write it down and bring it back to a subsequent meeting, or at least try and explore it outside the current framework of the agenda. Have the agenda with a purpose. What are we trying to achieve by meeting, and what would a good outcome of the meeting be? Always review whether the meeting was useful or not. If it was useful to discuss purpose, why? Did everybody get to speak? Were people feeling that they were participating? On a score of 1 to 5, 5 being great, was it a 5 meeting or a 4 meeting, or were there loads of interruptions and the IT didn't work and it was a 3 meeting? Think of your own way of gauging whether it was good, medium, or less than that. Always stick to time. In fact, great meetings finish just before the predicted time, the planned time, if they can. And a meeting that's an hour is already too long, in my experience, not least for quality improvement, because you can talk about it forever, but unless you do something and try something out, you're never going to know. So this is a really important discipline to keep. And as I said, carve it out of an existing meeting. 10 minutes would be a good start next week. That's all it takes. You need to give yourselves permission to speed up a little bit on the other work and carve out 10 minutes to talk about what we've been discussing today. Next slide, Matt. These are the functions. So I've mentioned timekeeper and you've tried that out, but have a leader for the meeting. Some systems call it a chair. In Microsystems, they call it a leader because the idea is it rotates. It's not always the oldest person or the most senior person or the person with the right title. Change it round, and that person prepares the agenda and moves through the agenda so you don't get hijacked at some stage by something that's just come in from left of field. Timekeeper keeps you to time and ideally would keep you on time through the agenda. The worst thing is to spend the 90% of the time talking about one topic and never getting below halfway down the list of things that you were going to talk about. Make sure you keep notes. Now, I think it was in one of the meetings this morning that the team were talking about this, but you know, sometimes we make a big deal about the minutes. They're typed up and they suddenly arrive a few days before the next meeting. That is not going to help you accelerate your improvement. Minutes need to be punchy, they need to be about what we're going to do, and maybe some of the background data that supports that. You can write them down on a board or a sheet of paper. You don't need to translate them into a Word file. Take a photograph and send it to each other on a WhatsApp so that actually everybody has the notes that were made at the time. Much better than losing things in the translation of somebody's memory notes and then typing it up on a system. It also means it gets to you that day, not at some later interval. And then there's a really important role called the facilitator, the person who's looking out to make sure everybody has been able to contribute. The person that noted that somebody was about to say something and then somebody else jumped in and they haven't had the opportunity to speak since. Somebody that knows certain people or maybe certain roles in the team are often quietly thinking about things and not talking out loud and thinking out loud like some people do. I'm one of the latter. And so they need to be asked, is there anything you want to say? Have you thought about, something that we haven't heard yet? Make sure everybody can contribute because everybody has a really valuable part to play in improvement and in the ideas that you are generating. So a couple of more things to think about. Next slide, please, Matt. First of all is the process map. You may have done this already, but process mapping is a really key thing to be able to do and do well and to do in an inclusive way. And we know that all your predecessors on this program have all used process mapping at some stage early on in their journey, because it does a few things. First of all, it makes everybody say out loud what their part in a process is, which means that some people will discover things that they didn't know actually had to happen. I always use an example of myself as a radiologist. I'd be all busy waiting for my list of patients to come into my ultrasound room, and I had to find out what all the new admin processes were in the office that were causing delays, because it wasn't obvious to me that the backup was being caused by new processes that come in from outside. As always, as humans, we invariably, blame the messenger or blame the people rather than think about the system. So it makes what is implicit, people's knowledge that they know about their own part of the job, explicit to everybody. It covers the things we do and makes us talk about the things that we don't do or we don't do very reliably. It means we have a map of what's going to happen, which we can then think about and modify and change in certain ways in order to make it either safer, more effective, more efficient, more equitable, more person-centered, and possibly also more timely for the patient and maybe better use of our time too. And we can always add and adapt it, and lots of teams put it up on the walls so that people can think about it, not just in the meeting, but outside of the meeting where that moment of inspiration may come through. Next slide, Matt. Here are some examples that from previous work. As you can see, this is around transition of a child. The idea that certain activities happen. You may want to embellish how they happen, who does them, where does it happen, how long should it take, what should it include. But you can see that this really gives us a very visual opportunity to think about the work we do, which we sometimes don't really pay enough attention to. It's kind of grown up. as they say, like Topsy. People have added things in here and there, and it's not always organised in a way that's best for the patient, for the patient's experience, or indeed for our experience as clinician either. Second thing to use with regards to actually looking at your work on top of being a better team is this fishbone diagram, it's called. A bit of a skinny fish with not many bones, but the idea being is that there's a problem or something that you're aiming to have an impact on, and there'll be lots of things that are contributing to that problem that need a bit of work doing on them. For example, the problem may be around flow through the clinic, for a certain clinic, maybe for your annual review clinic. And, you know, you can label the big boxes in any way you like. And often in our work, materials and equipment get added together, so the fish doesn't necessarily have symmetry. But it doesn't really matter. What matters is you're starting to break down the problem into things you can do in certain specific areas. The equipment you have, the processes you go through, what people do when they do, and does everybody know what the next person's role is, so that they can make sure that they do theirs as well as possible, so the next person's job is really easy to do well too. Is there something about the way you report, the way you collect information, the way the management of the system works that's getting in the way? Or is there something around the environment that can be tweaked? Everything from where the computer and the chairs go, all the way through to the timing of the clinic and whether you change the days of the clinic so that kids don't have to come out of school on the same lesson every time they come to you for an appointment. Something which tends to create DNAs, as I understand, in the teenagers, because of course they're missing the same lesson each week that they don't want to do. The point being is you're breaking a big issue down into small things that become much easier to make changes to. And then lastly, the whole idea of the plan, do, another example here, which is a pretty fancy fish, but here you can see some of the things that we use there, the language that we're using, how we might vary that with the kids that we're looking at, clinical room availability, how we're communicating with a different site, and so on and so on. You have these slides and see these examples, but a really nice way of showing the complexity of what's going on, but being able to drill down on one or two things visually and practically to make an improvement. And then the whole idea around improvement is we don't want to have a revolution and spend a lot of time planning the perfect new clinic arrangement. We want to have an evolution, because we're not going to know what the perfect clinic arrangement is until we've tried a few things out. We've learned how to do things differently, and most importantly of all, we've checked with the patients and their families that it really is an improvement, not just a change. So here is a single piece of paper that you can use to keep your Plan, Do, Study, Act activities on. The idea that who's going to do it, when are they going to do it, what are they going to do, how are we going to know it was or wasn't an improvement, what happened after we tried it out, and then in simple terms, is it the wrong idea and we abandon it? Should we adapt it a little bit because we discovered that this wasn't quite the right sequence, or this wasn't quite the right time, or this wasn't quite the right person, and we didn't have the equipment to do what we wanted to do? Or are we going to adopt it and now practice it to get it more robust and more consistent every day of the week in every circumstance we want it to happen? And so this goes back into the sort of the root of, next slide, Matt, of all improvement methods. The idea that we have to be clear about what we're trying to accomplish. We have to be clear of how we would know a change was an improvement and not just a change. And then what are our ideas and which ones are we going to test out to see whether that improvement is happening? And these are the three key questions that you need to ask yourself at every step. The point being is that if we can stick to the discipline of great meetings, and we can use some of these tools to look in detail about what we do, we're in a much better position then to make suggestions about how we would change what we did in order to make those improvements. Always touching back to the patient and their family to make sure that they haven't got ideas that we could use, and that their suggestions are embedded in what we do, and that we know that their experience has been improved as a result of the changes that we've made.